and talking about for almost half a century. I have no disclosures, and this is my plan. It's actually very simple. I will start with how do we not know Behçet syndrome with its subheadings, and then I'll go to how do we not understand what disease criteria are, and then I'll make a brief summary at the end. Well, there is a reason for this scheme. Very important figure in quantitative medicine, Dr. Fries, many years ago had said, presence of disease criteria affirms our ignorance of the essence of disease. What I now add to that is that we are in a state of double jeopardy, in fact, because we do not actually seem to appreciate what disease criteria are. So I'll start how we do not understand Behçet syndrome. And these are the strong and weak elements, as I like to call them, of the construct of Behçet syndrome. The strong elements, whether they can be sensitive or specific, are the oral ulcers, uveitis, major vascular disease, genital ulceration, parenchymal CNS disease, and I will make a few comments on each of these. But then there are also the weak elements. That is, those elements that sort of very strongly suggest that we are not dealing with a single entity in Behçet's. And that's the distinct phenotypic clusters, geographical variation, not only in frequency, but in disease expression, differing end organ response to different agents, and the almost impossibility of telling Behçet's from Crohn's in the setting where the extraintestinal manifestations are not present. Very recently, another strong element, if you will, was observed. Now, I have walked around with the slide for many years, which represents the inferior vena cava from a post-mortem, of course, of an unfortunate patient with Behçet's. And you will note that the lumen is sort of very thin, but the whole thing is like a piece of beef. The wall, the venous wall, is greatly enhanced. And I remember these were the days when the physicians joined the pathologies in the post-mortem examinations. This specimen was very difficult to cut with a pair of scissors. So I sort of showed this slide around and talked about it for many years. And more recently, my younger colleagues came up with similar observations from two differing and, if you will, rival institutions from Istanbul. And this is our data with increased vein wall thickness in Behçet's and similar observations from the Marmara University. But this is, and it's important that this observation is made even in those patients when there is no clinical venous disease. On the other hand, there is the tendency more recently to sort of use this as a criteria as well, but time is not ripe for that. I insist on advising my younger colleagues that we need more information, especially more structural information, biochemical information, immunological information, etc. Now, of the strong elements, uveitis is a very important element. This is the work of Dr. Tural Tutkun from Istanbul. And some years ago, about 8 years ago, she did, I think, a very important study. She took pictures of patients with the retina pictures of patients with Behçet syndrome and mixed them with, again, the retinal pictures of a variety of conditions that could be confused with Behçet syndrome. And she distributed those among the ophthalmologists who are very well versed in Behçet's. And just looking at those retinal pictures, they could tell which picture belonged to which patient. So it was a very specific finding. About a year ago, they expanded this work and they sort of came up with an algorithm. This ties rather nicely with some work I will quote we had done years ago, that uveitis is a very, very specific feature of Behçet syndrome. Another work is another observation is that if you're a neurologist well versed in Behçet tells you that a patient or a brain MRI or clinical findings of a patients with neurological symptoms has Behçet, do believe in him, in her, or because this brainstem involvement in Behçet syndrome is rather specific. On the other hand, when we come to the weaker elements, the issue of disease clusters is rather important. Now, this is the work we had done many years ago at Cerrahpaşa, and we had shown that 4 clusters of disease expression. Importantly, as I had mentioned, look at over here, uveitis was very strongly associated with Behçet's. And the presence of arthritis and papulopustular disease is another one, the skin mucosa findings, and importantly here, the presence of the superficial vein thrombosis with the deep vein thrombosis. Now, this clusters of disease expression was not very popular for some years, up to about a few years ago, when our colleagues from Japan and China came up with very similar clusters among their patients. But talking about these clusters, one thing is important. For example, 2 things are very important. First, in our cluster we had described some years ago, clusters rather, the GI disease clusters, which are who are usually HLA-B51 negative, by the way, was not present in our clusters because very few patients. This was on about 300 patients. This new patients this work was done on, but in the Far East, intestinal involvement is rather common, so that in those Chinese and the Japanese clusters, and all from Korea as well, intestinal disease is present too. On the other hand, I put those disease clusters under a weak pillar of Behçet's, in the sense that it's more than one disease, they represent more than one disease mechanism. On the other hand, those weak components, elements of Behçet's can help you with diagnosis, because if you have, for example, somebody with superficial thrombophlebitis, and he or usually he gets a severe headache, you immediately suspect that the patient has dural sinus thrombi, so that those things go together. So they help in recognizing patients and putting symptoms in one patient together. I mentioned that there are geographical differences in disease expression as well. As I've just said, GI involvement is rather common in the Far East, not so much at our part of the world. Eye disease is the most morbid situation almost in Behçet's, whereas although it's present, it's milder in North America, in Europe. Vascular disease is more common around in our area, but not so in the Far East. But rather uniquely, aortic valve involvement, occasionally observed, at least in our patients in Behçet's in Istanbul, is more common in the Far East. CNS disease, more common in European and North American series. And the pathology positivity, which we had formerly shown many years ago, is more common in our part of the world, and it's rather rare in North America. So these are the geographical differences in disease expression as well. I think a rather important topic on more than one disease mechanism is the differing drug action in pathologies at different sites. For example, colchicine, an old agent, is good for arthritis and erythematosus and genital lesions, mostly in females and not males, no data on its being effective in other lesions. Anti-TNF agents, they wipe out the oral ulcers, but they don't do anything to the pathology lesion that we had shown years ago, which strongly suggests different mechanism. So similar observations with the newer agents. So it is not like in Behçet's, it's not like in systemic lupus, that various amounts of glucocorticoids are almost good for everything. This is not so in Behçet's. Now we come to another very weak element actually in Behçet's. In this sense, we want to conceptualize Behçet's. And I really complain about the almost totally inductive genetic work research that we are involved in. Now, we are associations in general in searching for causality come rather low in the ladder. It's when we go up to the level of counterintuitive reasoning, then we begin to understand causality. So that whenever we see an association, whether phenotypic or genetic, we sort of induce that this probably is the cause, this association is one of the causes of Behçet's, of many causes. I think this is very simplistic. As I said, associations are seldom enough to understand causality. And this has led up, as this article summarizes the main pathway in mucosal ulcerating diseases, the concept of monogenic Behçet-like conditions like the A20 haplotype situation and the Behçet spectrum of diseases. And I think Behçet spectrum of diseases is a very good example of how inductive we are. This work is rather recent from NIH and from two Turkish groups. They claimed that first they looked at associations, genetic associations between two groups of conditions recurrent after stomatitis, PF-APA, condition, rather rare condition, mainly among the children, and Behçet's disease. And they claimed that this was a spectrum, Behçet spectrum, and there is what increased disease severity with stronger HIL associations. But the first sort of suspicion is that recurrent after stomatitis is almost seen at certain ages, around 15% of children. And of course, this is nothing like the frequency of Behçet's, but still, the associations, also not only HLA, but other genetic associations are there. What I'm going to point out in this article is the amount of induction these authors are using. So in this article, it says, many adults with Behçet's disease have reported symptoms earlier in their life, in childhood, that fulfill the diagnosis criteria, PF-APA. So they try to, after their observations, they try to find a reason why they did their work. It should be the other way around, you know. So the references they give, the reference 20, refers to a group of patients. This is an Italian group. They take patients with Behçet syndrome around age 42, as it is over here, and three groups of doctors asked whether they had symptoms as a child, PF-APA symptoms. So this is the rheumatologist, pediatrician, and the internist. It's rather unique that the rheumatologist, when the rheumatologist asks these patients, say, well, 30% of them say, I had similar symptoms as a kid. When it's a pediatrician, 10%, it's less than that when it is the internist. And another funny thing about this reference, of course, is that when the age, when they had those, was very, very preschool age. The second reference they give is sort of looking at this other way around. They take a report from a group of experts on PFAPA, which have longitudinal data. And they say, they quote, they look at how many of them develop Behçet's later on. And to cut the long story short, of the 60 patients they follow up for up to, I think, 2 decades or so, only one of them developed Behçet's, and that's debatable whether that patient had Behçet's. So it is a total induction in the sense, we had written an editorial about this with Dr. Ben-Chetrit, even the references are induced. So the references follow the findings, which is, I think, not very good science. To couple this, the genetic work currently people are busy with include very few family and twin studies for some reason. Some years ago, we had looked at the twin study of twins in Behçet's, and we had 6 monozygotic twins, only 2 out of 6 were concordant. Many years passed after there was another study on Behçet's, and this was a large Korean study published last year, and they looked for Behçet's among the first-degree relatives. And there were also monozygotic twins in this study as well. To cut the long story short, the frequency of monozygotic twins concordant for Behçet's was less than what we had observed. Of course, ours was limited to only 6 monozygotic twins. But what I want to stress is that if, let alone doing any studies of molecular work, but if people begin to look at genetic association studies in families rather than in groups, we will have more understanding of causality. For some reason, people refuse to do this, and which I think is sort of a handicap in our understanding of Behçet's. Now we come to the other thing we don't really understand, what disease criteria are. Now there are some concepts that determine the usefulness of any criteria set, designated classification or diagnosis. These are actually 3: the sensitivity, the specificity, and the prevalence, very important prevalence of the disease, syndrome, condition, whatever in the setting these criteria are used for. So, cut the long story short, less frequent the condition is more specific, the criteria have more specific the criteria have to be. If
3 minutes, please.
Sorry?
3 minutes, please.
Well, I will finish if you let me. Less frequent the condition is more specific the criteria have to be. Otherwise, you make many false diagnoses at the price of missing a few. But then, more important, you should have a clear goal in your mind as to what you want to do with the classification or diagnosis. A good example, an unfortunate example of this was the 2010 rheumatoid arthritis criteria. This was not a criteria for rheumatoid arthritis. This was mainly a criteria when to start methotrexate in a patient with early arthritis. But they did not call this thing. Well, lo and behold, what turned out was, it understood by a Dutch study, a few years later, about 30% of patients, they had a different diagnosis. So there are 2 illogical inconsistencies in formulating disease criteria. Classification and disease criteria are different. Classification criteria is for research purposes only. No, there is no difference in the cerebral arithmetic process. There is no reason that we cannot use classification for diagnosis as long as we are honest with ourselves and our patients. The other thing is we must avoid circularity in devising criteria. No, making disease criteria aims for circularity. What we should avoid is forgetting you are being circular. This beautifully said on this Humpty Dumpty cartoon. Whenever it means just what I choose it to mean when I use it, neither more or less. But we should discuss that it is when it is less with ourselves and with our patients. This ICG criteria we had devised, it actually was done in my apartment. There was something unfortunate. The issue of prevalence was not addressed in these criteria. And then of the 20 different sets of criteria following this, none paid due attention to the disease prevalence. So in brief, I said that Behçet syndrome is very heterogeneous with weak and strong elements and clusters of disease expression. Basic research about disease mechanism, unfortunately, has been very genetic and inductive. There are conceptual, almost end-grade problems in formulating and using disease criteria. There is no reason not to use classification criteria for diagnosis as long as you know what you are doing and explain it to the patient. So, final slide is utilize the strong elements of the construct of Behçet syndrome to make your diagnosis. Preferably work as a team. Your most important team members are ophthalmologists, dermatologists, and neurologists. Get ready for discussions, debate with your gastroenterologist colleagues. Be very suspicious about the diagnosis of Behçet's in a young child, especially with affected members and the family, the unfortunate 820 situation, which has nothing to do, I believe, with Behçet's. Refrain as much as possible from being inductive in understanding disease mechanisms. And you can use a criteria set for classification for diagnosis as well as long as have a clear idea what you are using it for, consider its shortcomings, frankly tell your patient that there is always a margin of error in any diagnosis you make. Thank you very much.